I can't sleep when I lay in bed. Too much thinking in my head. I don't know what to do anymore. But come on now, tell me the score. Is there anything I can do to get out of these tragic blues? I'm a victim of circumstance. I never really had a chance. I lay down and stare at my feet. You know the world has got me beat.
Hello and welcome to today's edition of Mental Health Matters. We have a really great show in store for you guys today. Today we'll be talking about hospice care. We'll be exploring what hospice is, what type of services are available to the family members after their loved one passed away, and much more. Welcome to our show today.
Thank you, Jesse.
Thank you. We're delighted to be here.
Thank you. I'm so excited to have you guys on the show today because I really want to know more about hospice. And I know when I had wanted to get somebody on the show to talk about hospice, I knew that this was going to be a topic that the community really needs to hear about. As you guys know, there are so many myths around hospice.
Yes.
And, and I just really wanted the community to really hear about how hospice can be actually something positive instead of something negative,
Thank you.
As what people may think it is. I guess we can start off by, I'll have you guys introduce yourselves and what do you actually do and what organization you represent.
Okay, I'm Jody Norton and I'm the Director of Patient Care at Sojourn Hospice in Sacramento, and I oversee the clinical services of the program.
Okay.
And I'm Cindy Keenan. I'm with Sojourn Hospice, and I am the Area Director of Operations.
Nice.
So I'm responsible for primarily sales, and I'm also the volunteer coordinator.
Oh, nice.
And my name is Matthew Crooks. I'm the Executive Director of Sojourn Hospice in Sacramento.
Okay, nice. And once again, welcome to our show.
Thanks so much.
I guess I want to ask you guys, why hospice? Like, what made you want to get into the this particular area of healthcare, so to speak?
Well, for me, I've been a nurse for 30 years, and I started in oncology, and I really felt like we weren't I wasn't able to practice in looking at the whole human being. I was focused on their physical being and didn't have time, because of the way the nurse-patient ratio was, to sit down and really delve into what was going on with that person when they have just given a life-threatening illness diagnosis, and just focusing on their bodies and not anything else.
Yes. Cindy?
I think just being able to focus on end of life and making sure that the patient and the family is also supported was really important to me, and that's why I transitioned from home health to hospice.
Oh, nice.
I was exposed to hospice care and workers from a very young age, and there's something very awesome in the traditional sense of the word about being involved with patients and families who are experiencing a life-threatening illness. And then the people who also are working in hospice are amazing people. And every week we have our team meeting and we discuss all the different patients and what's going on with them. And every week I get a little choked up just to seeing how brave that my whole team is acting, and the incredible empathy and compassion that they're exhibiting. It's amazing atmosphere.
That's awesome. That's awesome. So I'm sure a lot of people, like myself, want to know, what is hospice?
So hospice is a area of care that is for people in the final phase of their life, and Medicare requires them to have a diagnosis of 6 months or less and certified by 2 different physicians. And what hospice is an actual team of people caring for not only the patient but their family, and really having direction of their goals be directed by that patient and family. What is important to them? What is the focus of where they want to go in their next phase of their life? And the interdisciplinary team, which is an RN, a social worker, a chaplain, an aide, and volunteers, all are doing their jobs in meeting that patient and family's needs. So the nurse might be focused on pain management and symptom management so that they can actually address the other things that they want to address once their symptoms are managed. A social worker that is providing resource finding as well as emotional support, and I call them anticipatory guiders,
Yes.
helping them know what's around the corner. Chaplain addressing spiritual needs in a very broad meaning, from atheist to whatever religion they have. The aides are providing personal care, personal hygiene, assisting with straightening houses and providing that a broader just well-being in the home. And then the volunteers who are there to provide either relief to the caregiver so that they can get out for a little bit, or focused on a task that the family wants to get done.
Wow, I think that's really awesome, because I know for myself, I really didn't know a lot about hospice, and I'm sure like many others, when you hear hospice, you just think of, oh, this person's going to pass away, and that's it.
Doom and gloom.
Yeah, exactly. But it's much more than that, because what I'm hearing you say is, not only does the client benefit from hospice, but the family also benefits from hospice. You guys have, the spiritual advisors, and just a lot of other things that go along with this component, And so I think that's really, really awesome.
A lot of times people think hospice is a place.
Yeah.
Like it's a hospice building or hospice house that you move to before you die. And hospice is ultimately basically a philosophy of care, about looking at the whole person, all aspects of their emotional, psychological, spiritual, and it's also looking at the patient and family as a unit.
Yes.
And supporting the family around the person who is experiencing life-threatening illness.
Yes.
Our social workers and chaplains do a lot of emotional support and counseling with the families to help them prepare and help them to cope with the anticipatory grief before the patient actually dies. And our whole focus is looking at how can we make the best quality of life for this patient, emotionally, in all different aspects. And so that's what our whole focus is.
Yes.
And we provide the care wherever they reside. So whether it's their private home, a board and care, a skilled nursing facility, or a residential retirement center, we can go wherever the patient is.
Yeah, that's awesome.
We've gone to motels where people are staying, long-term motels. We've even gone to homeless shelters.
Wow.
To follow up and take care of our patients.
Wow, that is really, really awesome, and it's really eye-opening once again for somebody like me. I know I had I visited you guys site on I think it was last Wednesday, and so I got a chance to chat with Jody and Cindy, which was really, really awesome. You guys really kind of opened my eyes up to the hospice world, so to speak. And I think this kind of go along with what you're saying, Matthew, but one of the things you communicated, Jody, was you talked about how some patients that's in the hospital, they'll get a life-threatening diagnosis from a doctor, and and when they get this diagnosis from a doctor, it's just like it's over, that's it, which leaves the family members in a traumatic state of mind. But the services you guys provide, you come in there and you kind of ease that blow, so to speak, and turn it into a really positive experience for the family members that's really, left with this particular situation, so to speak.
Yeah. So you addressed my pet peeve is when a physician comes into a patient's room and says, there's nothing more we can do for you. And that just kills me, because the opportunities are immense. Now the care is given back to the patient and family. So there might not be technology and labs and invasive things around the corner, but there is so much more we can do for them in symptom management, for one, but as well as just really what is it that you want to complete before your end of life? What is important? Is there a relationship that needs to be mended? Is there a place or a person that you need to see? What is important to you as an individual? We can also help them develop ways to leave legacy, whether it's a letter or really having them do some life review and life story.
Yes.
So there's so much more to do, and it isn't about your life ending. It's about whatever we can do to make this the most quality time for you before none of us know when our
Exactly.
last days are.
That's exactly
and
right.
whatever the most quality days can be, that's where the emphasis is with
Wow.
hospice care.
Wow. So tell me this, what type of services is available to the family members after the loved ones have passed on? Or is there any type of services available to them?
That's a big part of hospice.
Okay.
And we're required to provide bereavement services for up to 13 months to family members after the patient has passed away.
Wow.
And we do that in various ways. It's driven by the family, and so we can do as much as doing weekly or in-person counseling. We can do it over the phone, whatever frequency the family needs.
Wow.
And then for people who don't really want that, then we keep in touch with them with letters and help educate them about the normal stages of grief, and so it help to normalize what they're experiencing. And we do those letters 3, 6, 9, 12, and 13 months.
Wow.
Those go out to everybody. Yeah.
And see, this is why I so wanted to have this show, to do a show about hospice, because, like, once again, myself, I would have never thought that a service was provided to the family even after their loved one passed on.
Right.
Me not having this particular knowledge, I was thinking that, okay, once the loved one passed on, that's it.
Yeah.
But it is important that the loved one do receive or have services available to them, because they're grieving.
Oh, yeah.
They're going through
Absolutely.
things as well,
And a lot of times the families are exhausted from caring for the
Yes.
loved one. And so they're dealing with all kinds of change.
Yeah.
And so we also have our chaplain or social worker follow up with the families a day or so after the patient's passed away.
Yeah.
To
Wow.
do some outreach and let them know about the bereavement services. We can do groups as well.
Wow.
And there's a lot of hospice agencies in the area have support groups for, it could be for spouses, or it could be for children. It could be for under 18 children who've experienced a loss. And so we'd like to refer them to different things like that as well.
Oh, awesome. So, what does Medicare hospice benefit cover?
Okay. Well,
great question.
It's a great question. The Medicare hospice benefit, which most insurance companies follow suit.
Okay.
And so it's all pretty much the same.
Yeah.
It covers all of the clinical services that Jody described to you, in terms of the nursing, social work, spiritual, home health aid, and then the bereavement services.
Yeah.
We also provide all of the medications that are related to the terminal diagnosis.
Oh, wow.
So, for example, pain medications or other analgesics, and medications for nausea, vomiting, any of those side effects that are common. We provide all the medications for their comfort.
Wow.
And then we also provide all the medical supplies they might need,
Oh, wow.
as well as all the equipment they might need. For example, hospital bed, wheelchair, walker, etc.
Yeah.
Yeah.
So, is this equipment in the company at their home, or do they have to come? Okay.
No, we'll bring it to where they live.
Oh, wow.
Yeah.
Wow.
And that's everybody's Medicare benefit. So
Wow.
it is an option. The part of Medicare that is usually in line for hospitalization is revoked, and they choose hospice Medicare benefit.
Okay.
But the lovely thing about that is with Medicare, there's a lot of hoops to go through usually, but with the hospice Medicare benefit, it's literally a signature on and a signature off if they choose to come off the service. Say they improve and they want to seek some more treatment, it's literally one signature, and then they can go back to standard Medicare in the hospital component of that.
Oh, okay.
Sure. And a lot of people don't realize that you can go on hospice care, and then you also can graduate off, or you can choose at any point at any time that you want to handle your care differently.
Okay.
And it actually happens quite a bit.
Okay.
Probably about 10-12% of our patients graduate off of hospice for various reasons.
Often symptoms are just stabilized, or their condition has stabilized with some really good oversight, and so they just start doing better, and so
Okay.
they
Yeah.
come off the service, and we
Yeah.
call it graduating off the service. And
I
want
like
to
that
share.
term.
Yeah, we call it graduate.
Term.
I want to share one story about a patient that we worked with, And it was a very elderly lady living in a dementia care unit in a assisted living building. And she had not spoken or walked for about 2 years. And that her physician felt that she was approaching the end of her dementia, and so he referred her to hospice. She also was extremely combative and would scratch and hit the staff when they tried to do personal care with her. So our team went in, and we have so much attention on our patients that things that are overlooked in the normal medical community, we notice. Okay, and so one of the things that they noticed that she, even though she didn't appear that she had pain, because our nurses are pain specialists. They're able to assess the nonverbal signs of pain. Okay, so they got her going on some symptom management for pain. All of a sudden, she's not fighting when they do the personal care with her bathing, dressing, because she's not now she's not hurting. And then we noticed that that she had a history of being bipolar, and it was no medications and no treatment for it at all. And so we had a geriatric psychiatrist go out there to evaluate her. And even though she was not speaking, he was able to evaluate her, and he decided to put her on a trial of some Depakote. 2 months later, we had to graduate her because she was up running around the building. And her quality of life was so profoundly impacted. She was going to activities. And when we met her, she was curled up in her bed, nonverbal, non-speaking. And so we're just thrilled, and so proud of my team for coming together and putting their heads together.
And I really like that component of the services you guys provide, because once again, when you hear hospice, you hear this doom and gloom, but you guys also seek to help the patient not only manage pain, but to get better. If that is, if they could get better, so to speak.
Definitely.
So
definitely.
That's
and speaking
awesome.
of the myth, they often think that we're just going to come in with our, black capes and literally they guide us. They guide us in what they want to talk about. We are very, very approachable and will bring up the subject of death and dying. But if they're not ready to talk about that, we let them be the guides. We are there to walk alongside them, not to direct
That's awesome.
the care. So
That's awesome.
Hence the name Sojourn.
I like that. I like that.
On your journey.
So I want to kind of talk a little bit more about the medication piece, because I know you guys say that the medication is in the home. So if a client is experience pain and they need this pain medication, how is it distributed to the client?
That's a great question. So usually when people come on to the hospice services, we get something into the home called a comfort pack. And that is a group of medications that sometimes are required for somebody as they are declining. And it is a little bit of morphine, and it's a little bit of lorazepam. It's also a medicine for secretions if they develop. There's medicines for nausea and medicines for restlessness. However, we might not ever use those. We have them in the home because we never want somebody to have some new symptom arise in the middle of the night or on a weekend that we are then trying to get orders for and get filled. We do have a 24-hour-a-day physician. We're also required to be available, and a nurse answers the phone 24 hours a day for the patient. So if they have a new symptom, it's literally a phone call, and it doesn't go through a pager. It literally goes to the nurse. So that nurse would then come out to the home no matter what time. We have a motto of start low, go slow, and being present for the first dose of whatever medication is. If it is pain medicine, we do have a gold standard of liquid morphine. And the reason we use liquid morphine is that it can be titrated up and down very, very easily, down to the point of 0.1, which would be an equivalent of a Tylenol. And so we start with a small dose, see how that person, everybody is so unique and individual, and what manages one person's pain might not touch another's. So we start with smallest dose and then titrate it up to make sure we're covering the medicine. We would only start them on around-the-clock medications if they were having a lot of breakthrough pain or incidental pain throughout the day. And if that's the case, then we try to keep the pain medicine very even instead of, cycling up and down off of medicine. But yes, start low, go slow. I think often people think that we come in and immediately start morphine and immediately their affect is dulled, and that is, we don't want to do that. We actually want them to be as present as possible for this period of time.
Yeah. I once again, I know when I visit you guys on last Wednesday, I really felt that you guys were really ethical, professional, and really down to earth. And you guys shared a lot of stories with me that stuck with me, And I do want either one of you guys to kind of touch on the story about, because I want people to hear that you guys go beyond the services, so to speak. But I want you to touch on the story about, I guess, one of the families didn't have a bed or beds, and how you guys was able to step in and help them out.
So we recently had a young woman on our services whose family lived in Solano County, and they really wanted to move closer to their loved one, and they found an apartment, and they really didn't have any furniture for that apartment. And so the social worker did some research and found an organization that would meet their needs of providing. They actually got 2 beds and a table, and he was able to get a truck to go and pick that up, and they deliver it to their new apartment, and they had a place to sleep, and
awesome.
it was wonderful. And that same family, just to share, after their loved one passed away, we knew them to have little resource, and so our team decided to adopt them for the holidays.
That's awesome.
We were able to deliver literally baskets and baskets and baskets. Took 3 cars to take over of
awesome.
personal care and food, and to help them celebrate the holiday. And we knew it was going to be such a difficult holiday for them. And so we were able to take that over and gift. And the whole team was just so involved in that and so loved being able to provide them.
Wow. And I really appreciate that, having an organization in the community that's willing to do that, because I know it was really hard for that family.
Tremendously difficult.
Yeah.
I have another bed story.
Okay, let's hear it. Let's hear it.
One day I got a call from one of my nurses, and a patient that we just had a hospital bed delivered for to his home. They had, because of the way that the house was laid out, they had to take he and his wife's bed out of the room to get the hospital bed in, and so she was going to have to sleep in another room, and they'd slept together for 65 years or so, and right at this moment, the wife was so upset not able to be with him at night, and so the only thing they asked me if we would provide another hospital bed, so they have 2, and even though it's not covered by any insurance, I said, of course we're going to meet her needs. She wants to be near her husband at night. So we've got another one. They have matching hospital beds out there, and I did not know how much it was going to cost, and it turns out it was $1 a day.
Wow.
Just to be able to allow her to be able to sleep with her husband.
So important.
Wow.
65 years.
So important.
Wow.
Yeah. So sometimes just the little things.
Yes.
Truly.
Yeah. Why hospice, and why now? Because it seems like hospice is starting to be something that's being talked about more. A lot of people still, are under the radar as far as the myth is concerned, but it seemed to be growing. But why hospice, and why now, you guys think?
Well, one thing I want to mention, though, is that I read somewhere that 80 or 90% of all the healthcare dollars that each person is spent on their healthcare is done in the last 2 years of their life, and most of it is spent in the last 1 month of your life.
Wow.
And so what really is saying, though, is that we're putting people through very traumatic, invasive hospitalization procedures and not accomplishing anything. Their life expectancy is not changing. Okay. And so when we think like why hospice, why now, it's really also making a choice to not put people through multiple hospitalizations, because once you're on hospice, we are the emergency room.
Yes.
You don't go to the ER. We come to you to stabilize anything that's going to happen.
Yeah.
And so it makes for a much more peaceful life rather than going in and out, in and out, in and out of the hospital.
Yeah.
And it's very traumatic for elderly patients to be doing that.
Yes, I'm sure. I was talking to one of my coworkers today, and she was sharing with me how her and her family they put aside $50. I want to say $50 out of each paycheck or something like that, and this is all going towards the health care for their. I think she said her mom or her husband mom or something like that. So when they start to need this fund, then it would be there. And I think she said they've been doing it like for 6 or 7 years, which is really, really smart, because as we know, healthcare can be very expensive.
Yeah.
Right.
The beautiful thing about the hospice Medicare benefit is the patient and family never ever get a bill.
That's awesome.
Yeah, it's
So
100%
all of
paid.
those 100% paid, and all of those services come to you. All of the medications, like Matthew was saying, medications, equipment, and any supplies are covered. So even medications that Medicare covers a portion of them, but they still usually have to have a piece of that. So even those are now taken away from them. So it's a 100% covered entity of Medicare, and it's everybody's right, to have that Medicare, and they can choose their hospice. And I think there is so many hospices out there now in this new developing industry that I think it would be wise for patients to really ask or interview their hospices to make sure they're getting everything they can potentially get.
Yes. So have you guys ever known hospice to like move in with any patients? Is that doable?
There is 4 levels of care for hospice services. There's the routine home care that we've been describing in this last few minutes. There's another component of hospice called respite care, where the hospice will pay for the individual to go into a facility to be cared for if the caregiver is exhausted and just needs a break. So we pay for 5 days of care, and then they would go back home if the case be. There's also a level of care called continuous care, where the hospice does provide 24-hour caregiving. The criteria for continuous care is quite hard to meet. So we don't bill for it, but would have a nurse out there for several hours a day, and then we get the social worker and the chaplain and the aide to go, and then the nurse might go out. But we might not be able to meet the criteria for continuous care, so we try to make it meet by the team members that are involved as well. And then there's a 4th level of care called general inpatient, and that's for symptoms that are out of control that need really aggressive management, and they would go into a skilled nursing facility or a hospital that provides continuous care. We might have access to the pharmacy a little quicker. We might be juggling and trying to get symptoms that has been a little bit out of control managed more aggressively.
Wow.
And so those are Medicare levels of care, and all hospices are to provide those.
And once again, this information that's being shared, I'm sure, like myself, a lot of people do not know this.
That's exactly why we're so excited to come down here and
We're really
be with
grateful.
you to help educate the community about what hospice does.
Yeah. I know it's funny because I did reach out to several organizations, and I know during the holiday people are busy. But I know when I called you guys, I think I got a call back from Greg the next day. Like, oh yeah, I'll do it. Yes, my job is So.
I think that's part of what I think is our responsibility is we are specialists of end-of-life care, and it is our responsibility to educate our community and let them know what's available to them, and provide education to anybody that is interested, because I think in generations past, our technology has increased so much that people might not have experienced a death in their family. They
Yes.
might have had a loved one go to the hospital and they died there, and so they don't know what is available to them if they brought somebody home
Yeah.
to be present. And so I think it's really important that we let our community know that there is another opportunity available to them.
Yes. Well, I definitely feel you guys' passion, all three of you guys. So that's, when I, talk to him on the phone, I'm like, okay, he's very passionate about this, which is good, because I like that. I'm a passionate person. And then when I came to meet you guys, I'm like, okay, they're passionate too, so this is going to be a good show.
But a lot of times people think that hospice, you always hear the phrase, hospice came in. And people, I think that we're going to smother them and have somebody there 24 hours a day. It's we do periodic visits. We can visit every day.
Yeah.
But it just depends on what they need.
Yeah.
What they want.
And really our job is to empower, teach, support the family caregivers or whoever is caregiving, and manage the medical care.
Yeah.
We're not going in there to take over.
Yes.
Right. Yeah, very true.
So, and I know Cindy Party, if I'm not mistaken, do you recruit or deal with any volunteers? And if so, what do they actually do?
I do. So I am actually the volunteer coordinator. So
Okay.
what I do is I recruit people that are willing to come out and help us provide additional care to the patient. Medicare requires a 5% cost savings,
Yes.
which the volunteers provide that. So we have volunteers that come into the office and can do paperwork and help us do
Wow.
things like that.
Yeah.
Or we have volunteers that go into the home and or skilled nursing facility, wherever they're located, and provide. It could be an activity. It's basically whatever the patient and the family are requesting.
Companionship.
Yeah.
Activities. We can provide respite. It's whatever is
Play music.
needed.
Yeah.
Play
They
music.
also can run errands for the family.
Yeah.
They could help with doing grocery shopping, or there's just a lot of different things.
Right.
Tell them about the assessment you do.
So basically, when I get notified from one of the team members, usually the medical social worker, that a volunteer is needed, I actually can go to the home or speak with the family on the phone and just ask, what is it that they're going to really benefit from?
Yeah.
Male, female,
Yes.
volunteer, times, days, what kind of activities, topics to talk about, things not to talk
Yeah,
about.
I understand.
So just make sure that we're providing what they're
match.
looking for. Yeah, a good match.
So how do you like recruit the volunteers? Like, what method do you use?
A lot of times I'll go to the colleges and
Okay.
post things, reach out. Churches, we do some educational things at various churches. What else have I done?
Also, just your own personal
Word of mouth.
network.
Yeah,
you know.
yeah.
And the reason why I kind of want to touch on this too, because part of my job responsibility is I recruit volunteers to provide services to some of our older adults. And so I'm just curious to see what challenges have you faced with trying to get volunteers to, come in and provide services. Like, I'm just curious. Like,
Well, the challenges I've found is, it is a real commitment because they have to fill out some paperwork.
Yes.
They have to basically, provide us with a year of service that we ask for.
Okay.
There's extensive training that we
Okay.
do
That's
online.
nice. Yeah.
And also some office training.
Okay.
And it's a commitment.
Yeah.
A lot of people are very fearful of death and dying in hospice.
Right.
They don't want
Yes.
to be. They don't want to face it. They want to be around it.
Yeah, it's not for everybody.
Yeah.
And I think that's what's important about the screening process that
Yes.
we have, is making
Yeah.
sure that they're going to be comfortable around
Yeah.
people that are
But it's
end
it's
of life.
The volunteer program is a vital one for hospice. We're actually we're required
We
to
are
meet
required.
to do 5% of our total patient care hours
Yeah.
with volunteer by Medicare.
Yeah.
We take this very, very seriously.
Yeah.
And it's in a lot of ways it's a very beautiful thing.
Yeah.
Because basically what they're saying is that that a person shouldn't be just surrounded by medical professionals. They want to ensure there's an element of community
Exactly.
in that patient's life.
Exactly.
And it can be a challenge, but it's actually a very beautiful thing.
Yeah.
And
Very
I
rewarding.
would like to say that probably the majority of the volunteers that do come are as passionate as we are about
Yeah.
this work and
Yeah.
and really want to be present with the patients or really want to contribute to hospice and in any way in the office. I mean, there's so many realms of volunteership that can be
Yeah.
provided, and the people that are out in the patients' homes are definitely wanting to be there
Oh, yes,
and
exactly.
feel really good about the care they give.
The volunteers kind of draw upon their own personal interests. So like if they have pets, they might bring their pet to visit their patient.
Yeah.
Or if they like doing nails, you know,
Yeah, hand massage or-
they can help facilitate an audio recording of a message to their family,
Oh, wow.
or help do a life history review
Yeah.
and tape record stories from their childhood so they can preserve that for their families.
Yeah.
Write
There's
letters.
there's dozens and dozens of different things that they can do.
Yeah. So it definitely sounds like it definitely is a need for volunteers
Yes.
for
Yes.
you guys' organization. So I'm
Absolutely.
hoping people that watch the show, if they have a passion, or if they even know somebody who has a passion
Yeah.
for hospice, I hope they reach out to you guys because I know it's very important for the client, to get somebody in the homes that really wants to. Be there for that support system for them, and
Yes.
and it do kind of ease their particular situation, what they're going through, because it takes their mind off when you got somebody there to
Yeah.
provide companionship services and want to talk to you and really want to give that time to be there.
Well, and reminiscing actually has got a very therapeutic benefit to
Yes.
it. It floods you with endorphins and relaxes you, and
Yes.
and it can actually help make you more comfortable too.
Yes.
So it's pretty important.
Yeah.
So, I'm just curious, what is the history of hospice? Like, when did it begin? Because I know for myself, that's information that I don't know, and I'm sure that people that probably watch the program want to know more about how hospice began in the history of hospice.
Well, in the general scheme of things,
Okay.
it's relatively new.
Oh,
It's
okay.
well, it started in the early 70s in the United States. Prior to that, there was hospices in Europe, and it was brought to a first hospice in Ohio. That was 1972, and they were really having some really amazing experiences, and so they wanted to share. So you could literally go to their hospice and be educated on how they were providing care and how they were set up. It really began as a grassroots, more of a movement than anything else, and people would come back to their communities and find the volunteers that were required to make up this picture of holistic care. The Medicare hospice benefit then started in 1983, in which you could opt for the hospice Medicare benefit to be utilized instead of the hospital component. And it again is a shift in philosophy of being more focused on symptom management and the quality of whatever remaining life versus doing aggressive treatment, which could be very invasive. And so it became an option, and slowly but surely, and with this opportunities to educate people that everybody who has Medicare has the right to hospice services and has the right to select their own hospice. Slowly but surely, messages got out there, and now it's a very common thing, but still remains scary for some people because they don't know. Along with the word hospice comes all these different fears, and so the ongoing education is completely required.
Yeah, and I think one of the reasons why hospice is brings such fear to people is because people don't want to die.
Yes.
People don't want to talk about dying. People don't want to talk about death. They feel they're going to live forever.
Right.
Yeah, I always say denial in a river in Egypt.
Yes. Yes.
Yes.
I know for myself, I used to be one of the ones that talk about death. Like, oh no, no. But as I start to mature and and in my faith, it kind of gave me hope. Like, okay, it's not such a bad thing, but even to the point of putting together will, or just putting people in place as beneficiaries and stuff like that.
Yeah.
I found a lot of people, especially in the African American community, they shy away from that because they don't want to deal with it. But the reality is, we all was born to die.
Exactly.
Right.
That is our
scary.
philosophy is that death is just as natural part of life as
That's
birth
exactly
is.
birth.
right.
You know, and I always say that ask people, do you know what the leading cause of death is?
Wow.
And people say smoking, car accidents. No, it's birth.
Yeah.
Yes, because every one of us is going to do it. And I think that, again, is our responsibility to normalize and take the fear away through education and support and guidance. And I think one of the biggest responsibilities of all hospice clinicians is that anticipatory guidance.
Yeah.
This is what we're expecting in the next days or months, and to help them feel less fearful of it. Again, it's often the first time they've been experiencing it for themselves, and the fear is overwhelming.
Yeah.
And so,
Medicare just this year developed new billing codes for physicians that specifically will compensate doctors for having end-of-life care planning discussions.
Yeah.
Because it does take, it takes a lot longer to have those kind of discussions.
Yeah.
As you can imagine, in your doctor's office. And so Medicare is trying to encourage doctors to be more realistic with these patients.
Yeah.
And be upfront to give them education.
Yeah.
And we're kind of hoping that people will get hospice care a lot earlier than they have in the past.
Yeah.
Our length of stay is really short.
Yeah.
Yeah. Because people tend not to refer to hospice until it's the very end. You know. But the criteria is that in the normal course of this particular illness, the physician is certifying that if it progresses normally, then it will probably limit their life within about 6 months.
Yeah.
But doctors don't have magic balls. They can only make a good guess, and it's perfectly okay for people to be on hospice for much longer than that.
Yeah.
We don't have to. After 6 months, we have to kick them off.
Yeah.
We can recertify them as long as they're still declining.
Yeah. I think what would be good too if physicians in general will have to take some type of crash course about hospice, because, like you said, your pet peeve, when you tell a family this is it, there's no I can do. I like the way you put it. You said that, it's kind of like, to some people, the physician's words are like God.
yeah.
Yes.
Right.
So, boom, that's it. It's, and they leave out of there in some form of traumatic experience,
Yeah.
And it does, right. And it messes with them mentally.
Yeah.
So if they had to, during their residency or whatever, if they had to take some type of crash course on hospice and the benefits of hospice, I think a lot of people would be able to deal with the end of life process a lot better than what they are now.
And it is starting to be a part of a lot of medical school programs. And I think that discussion of how to have that discussion, no one wants to be the first one to come in and say that this disease has progressed and we're at a point where we need to look at other options. But there are really positive ways to approach that are not so scary, and it doesn't feel like your physician, who they might have had a long-term relationship, is now abandoning them. Because that's really not what they should be. The message shouldn't be that. The message should be that we're in a different phase now, and there's a shift of hope. There's a shift of coming home again and being with your family and being in an environment that is just very focused on making this full and rich. And that is the message should be given. Not that this is the end of it is the end of your life, and we are looking at it, but there's so much richness that can be involved.
Yes, and I do agree with you on that. Like you said, just putting together like family portfolio pictures or just things that you can do that's really constructive while you're still alive, that you can actually hand down to your loved ones.
Yeah, I'll share a story of the most loving thing that I have. Well, as Matthew says, there's lots of loving things weekly that we hear that our clinicians are providing.
Nice.
But we had a social worker that was out in a home that had the person who was dying was a man who had been estranged from all of his children. And the estrangement occurred because he was in a band and he traveled constantly. And so that was his passion in life, and he hadn't really put a lot of time into his relationships. Although he loved his children, he was afraid to reach out to them. So she put together this whole, it's just a brilliant idea. She put together this whole book of his important moments in his life, his marriage, his first date, his child's birth, and what was the music that was important at that time. She then went and found the record covers of every song that he said. So during the marriage, there was one record, one specific song important to him. During the child's birth, there was another. And it was this whole book of record covers that had a story that went along with each of those moments. And she asked if would you like to share this with these estranged children that were willing to be a part of his life at this end phase. Wow. And they all came together to share it. I've never witnessed something so beautiful as that. They wept, they remembered, they shared stories. They just had this opportunity that they might not have had otherwise. And he died 2 months later, very connected to all of his children who visited regularly.
Wow.
It's just an incredible idea.
Wow. So, okay, once again, we know that when we think about, hospice, it's to me, you guys are really shining a light on this particular subject, and I'm really hoping that people who watch the show really get some out of it. But I'm curious to know, do hospice patients, do they just stay home? Do they drive around? They go on vacations? What do they do?
It's a really good question. It's a really good question. Hospice, so with home health, you are supposed to have homebound status. With hospice, we encourage people to be in their lives. We have people go to casinos. We had a patient that had never been to Hawaii, and we made arrangements with the hospice there to follow. We rented him a wheelchair with beach wheels, which are like these big wheels, so he could come down on the beach and get his feet in the ocean. We encourage them to live their lives. We have somebody that goes to a weekly card game, and we encourage them to be in their life. Sometimes if they're in a skilled nursing facility, we get them orders to have a leave of absence so they could go to their loved ones for a couple of days with their medications and all of their equipment that they might need. So we try to anticipate everything that they would need, and then we make it happen.
Wow, that's awesome. So they just not stuck there.
No.
There's no restrictions at all in terms of that. And we try to rise to the challenge of that creative problem solving. Wow. What could this patient wants to do this? How can we make this happen? We do a lot of brainstorming.
That's awesome.
Got a man who has extraordinarily short of breath and wanted desperately to walk his daughter down the aisle. We put him up in a hotel the night before so he could just literally be almost on the premises, and just brought him out of bed right before that one walk. Wow. And with a little oxygen and a lot of support from his family, he was able to do that. And talk about heart moving.
I think how much that meant to him.
And to his daughter.
His daughter.
Just will never forget that.
You
never forget that.
But once again, these are the type of stories that's not being told when you talk about hospice.
Well, as you can kind of get a feel, is that we're medical providers. But our focus on the psychosocial components of death and dying is what our real talent is.
Yes, exactly.
I mean, we have expert symptom management nurses, but our nurses are also talking about all of these psychosocial things too. It's truly a truly multidisciplinary team.
Right. So it goes beyond the textbook.
Yeah.
Because
Correct.
you got real people with real
Exactly.
emotions providing these services.
That's well said, because the textbook tells you about the illness and the disease.
Exactly.
It doesn't tell you about the being
Exactly.
and what's important to them.
Yeah.
That's well said.
Exactly. So tell me, how can hospice alleviate a person that's dying physically, emotionally, and spiritually? You know, how can it, you know?
So I think in those, you know, that's our business every day.
Yeah.
We are alleviating symptoms by, and we do have specialized nurses that are certified in hospice and palliative care.
Yeah.
And they really know how to assess for symptoms that maybe other clinicians are overlooking. At the same time, the medical social worker is going into the home and assessing psychosocially, how is the family doing? How is the patient doing?
Right.
Have they been able to talk about their experience? Have they had a safe place to share? Because we all tend to protect each other within a family.
Yes,
and so
yes.
they often will help them navigate that protection and sometimes mediate patient and family visits, meetings. Our spiritual care counselor is going to meet that patient wherever they are. If they're just talking about the meaning of life, that is spirituality. Or if
Yes.
they're wanting specific rituals based on their religion,
Yeah.
they'll provide that. If they're wanting to have a connection with their church, we have facilitated, priests going in for Sacrament of the Sick.
Wow.
And so we meet them wherever they are. And one of the things that I think is really critically important to all of us is every time we knock on our door or enter a room, that is their own culture.
Yes.
And we are to respect, to honor, and to help them feel very comfortable. We are being invited. We are invited guests into that
Yes.
home, and wherever they are, no matter, all walks of life, there's no right or wrong way to do this.
Yes.
And we are there to respect and honor that and to walk them through no matter what their culture is.
Wow.
Yeah.
Yeah. And I like that as well, because I know sometimes when you have people that's providing services from the community, sometimes clients, may get the interpretation that they're there to take over because they're the professional and they know what's best. And so you guys definitely doesn't wear that hat. You respect their
Absolutely.
space, and you're there as a guest to help them, as they need
Navigate,
it.
yeah.
That's
Yeah.
awesome. That's awesome. So what if a client fall and break their hip? I'm just curious. And are they still allowed to seek help from the hospital, or is it just they're not?
So what we ask them to do is to call us, and we come immediately out and evaluate. And yes, if there's somebody with a fractured hip, we don't want them to be in a severe pain. So
Yes.
we will. I have had a variable of situations where yes, they want to go to the hospital and they want to get it evaluated, and if they can fix it without surgery, they want that to be done. A lot of our hospice patients are not surgical candidates, so we need to find out what can we do. Where is the fracture? Is the fracture able to be managed there, or do we take them home and manage their pain via medications? Had a variability of things occur, but yes, they can go. We in some ways we're considered like an H&MO.
Yeah.
So we call this first, and then we come to you,
Yes.
make the evaluation, and then yes, we might need to go to the hospital for that, and we would cover that.
Oh, that's awesome.
Yeah.
That's awesome. So
in other words, if whatever's going on is not related to the hospice diagnosis, and there's no concern,
yeah.
a lot of times we can address an acute problem in the home though.
Yeah. Yeah. Yeah.
So we just try to avoid having to go to the hospital. We're faster than the hospitals are.
Yeah.
Definitely.
And
And to them,
Emergency
come to
room.
them
Yeah,
instead
we
of
come
they
to
go
you.
to somewhere else.
Yeah.
so what do you guys see hospice in the future? What's in store for hospice in the future? Just real quick.
Yeah, I'm running close to time. So
Yeah.
I think what's around the corner for hospice is that I'm hoping for children right now, you can have both some treatment and hospice services at the same time. I'm hoping that that's available for adults as well in the near future. And the reason is there's a hole between hospital meeting home health criteria and qualifying for hospice. And I hope that we can start care earlier in the realm. They might not be completely done with treatment, but we can come in earlier. As Matthew was saying, we are often getting referrals when people are in the last days of their life.
Yeah.
And that's not fair to them. It's hard. It's like hospice SWAT team, and it's just not a good way. So I think we'll be able to broaden care down the road.
Okay.
That's my hope.
Yeah.
Okay, and thank you guys so much. I know we've been out of time, and I thank you for being on our show.
Thank you
and
for
that is
inviting
it
us.
for today's edition of Mental Health Matter. If you like our show, or if you need more information about the show, please call 916-366-4600. Thank you.
Thank you.
Thank you.
When I think of where I've been, the good times and the bad, on a scale of 1 to 10, either way I'm glad, 'cause I'm not alone. As I'm reaching for the phone, your voice is there, you really care, you're my comfort zone. Sometimes when I'm lost, crushed beneath the pain, though I can't afford the cost, I just smile and play the game. But there's a healing place where I cannot pretend. Your smiling face, your heart's embrace heals me again. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song, and I simply can't deny that I'm not alone. 10,000 times I've known my best bet is that first step for hope. Trying to stand tall, I'm haunted by the past. With my back against that wall, one thing is clear at last. The kind of love you show to me flows from an endless stream, with shores so wide it won't subside. My mind had never dreamed how I'm not alone, even when I'm on my own. Your gentle touch is much too much to let me roll. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song, and I simply can't deny how I'm not alone. 10,000 times I've known my best bet is that first step for hope. When I think of where I've been, the good times and the bad, on a scale